Tips with Toni. Tips with Toni. All about nutrition from your favorite dietitian. Everything you need to digest in your mind. Tips with Toni. Tips with Toni. Making you healthier one bite at a time. Tip with Toni. Woo.
Hello, and welcome to the Tips with Toni podcast. I'm Toni Marinucci, your registered dietitian, helping you get healthy one bite at a time. This next interview is with a good friend of mine. Her name is Andrea. She's also a registered dietitian. If you haven't gotten the trend here, I tend to interview a lot of other registered dietitians. But the cool thing is that registered dietitians are able to specialize in different areas, and Andrea works in a bariatric center, an outpatient, and I thought it would be absolutely perfect to bring her on because I get a lot of questions about people considering doing bariatric surgery or post-op, a year out, 6 months out, 2 years out, and I get a lot of questions, so I figured why not bring on an expert in this area. So I also wanted to bring her on because I also hear a lot of people say like, oh my God, this person lost 150 pounds doing bariatric. Like, is it going to work for me? But we don't really know what is going on in that person's head, in that person's life. And there's a lot of things to consider before deciding to go for an elective surgery. So with that being said, I wanted to have Andrea on to talk about the pros and the cons, what to consider, how your life is going to change forever and indefinitely, just to make sure you have all the facts before coming to a decision. As always, you always want to make sure that you discuss with your doctor, your registered dietitian, and really weigh out, the benefits and maybe some of the sacrifices that you're going to make before coming to a decision. So without further ado, here's the interview. Hi, Andrea. How are you?
I'm well. Hi, Toni. How are you?
I'm great. I'm so excited to talk with you today.
Yes, lots of fun stuff.
Yeah. So before we get into this very interesting topic, just introduce yourself to everyone, say who you are, what you do, and why you do what you do.
Okay. So my name is Andrea Doria. I am a registered dietitian. I've been a registered dietitian for 18 years. I've been working basically exclusively with bariatrics for the last 5 years. I work at an outpatient office at a hospital. And then I also do online coaching with some clients as well. And why do I do what I do? I actually ended up in kind of the specialty of weight loss probably about 10 or 12 years ago. I worked for Fred Hutch Cancer Research Center on a weight loss study. So I became certified in weight management, and we did weekly visits for the first 6 months because the study goal for participants was 10% weight loss in 6 months. And it was a very successful study. Over 400 women participated, completed, reached their goals. So that was like a great opportunity for me. And then kind of shift from Seattle back to New York, and then eventually ended up with bariatric practice. So.
Wow. Very, very cool. And I love that you said that study was successful, because I know today I read it over and over again that with just 10% of weight loss, people can usually get off their medications and they can see dramatic improvements in their health, lower blood pressure, lower their cholesterol. And so many people underestimate the small changes of just 10%. And it's not just 10%, like 10% of it is a significant amount to improve your health.
And huge in the area of prevention. So we did breast cancer for prevention, but it's amazing for things like, prostate cancer prevention and colon cancer. And so it is significant. It maybe doesn't look a lot on a scale, but it's definitely a huge impact in health and well-being.
Totally. Well, so I want to talk about bariatrics, but before we do that, did you grow up a certain way around food? Like, is there a reason why you became a registered dietitian in the first place?
So yes, I grew up in an Italian household. So typical kind of most cultures I found working in this field, like food is an emphasis. Food is definitely something that everyone gathers around and enjoys. So my father happened to be diabetic. So I learned very young kind of the impact food had on health, or harming health over time. So it's definitely kind of what brought me into the field initially.
Yeah. I'm Italian as well, and my father is diabetic, and his father is diabetic, so I know how that is for sure. Does your dad listen to you? Mine doesn't really.
No, he did not at the time. So I would say one thing, and he used to sneak food. It was actually very funny, like over time, to be like, we're little kids and you're like hiding food from us, but like, we're not going to put you, like, you're not going to be in trouble because we saw you. So
he knew he was not doing the right thing.
Absolutely.
Wow. All right. Well, so anyways, the topic today is all about bariatric surgery, because I know a lot of people have actually asked me if they think they'd be a good candidate. There's some people in my Healthy Lifestyle Support Group, which I know you participate in. So thank you for your participation, by the way. And a few people there have gotten the surgery or considering it. So I just thought it would be a perfect opportunity to bring you on to shed some light on this. So before we kind of talk about like who it's for and who it's not for, could you just explain what bariatric surgery is, what kind of falls into it? And yeah, just go from there.
Okay. So bariatric surgery, there are a few different types of bariatric surgeries, and they're either restrictive and malabsorption component to them. They're initially about 10 years ago, they started actually phasing out the lap band. But there is a lap band, which is just an external kind of apparatus that goes around the top of the stomach, and it creates a very tight restriction. So when you're trying to have food pass through from the esophagus into the stomach, it has to be really well chewed. It has to be very like liquidy form. Mm-hmm. However, the size of the stomach is the same. So it isn't as difficult to eat larger portions, just takes a lot longer.
Right. So it like forces you to slow down your eating, to really, really chew your food. And then, okay, gotcha. So that's the lap band. And then they're not really doing it so much.
So they're not doing it as much. There are some considerations as far as complications down the road. The band itself can erode the outside of the stomach lining. It can slip. There's actually a port that can kind of get flipped around. And so in general, most people end up having to get it out at some point. And in addition, the ability to sustain weight loss has not been shown to be as effective.
Gotcha. Okay. And then the other surgery?
So vertical sleeve gastrectomy, or we just call it the sleeve, that is a procedure where the stomach is taken from, let's say, the size of a football to about the size of a small banana. So about 80% of the stomach is removed, and the digestion process is the same. So it's strictly restrictive. You're unable to, eat large portions at one time, but there is no reaction to sugars, excess sugars. Most people tolerate them fine over time.
Okay. And now with that, could the stomach stretch out again? Could it go to a banana and then go back to a football?
Technically, it does get bigger over time. How much bigger? I don't know that it goes exactly back to the same size even after 5 years. But the process is, it's a flexible muscle. So if you're following the guidelines, you're less likely to have extension of the stomach for longer periods of time throughout the day. So it shrinks back to that small banana more rapidly. But if someone's overeating and having several meals throughout the day that are causing this distension to last longer, or having carbonated beverages, their tolerance for a larger portion increases faster.
Gotcha. Now, are there any other surgeries that people should know about?
So the other option is called a Roux-en-Y, or we often abbreviate it and we just call it a bypass. The reason being, a very small portion of the stomach is cut away and kept. And that is like a pouch. It's about the size of an egg. And there is also rerouting, where the lower part of the small intestine is then attached to this little egg. So food now passes from the esophagus into the small egg-shaped pouch, and then out into the lower part of the small intestine. It now food bypasses the stomach and the beginning of the small intestine. The early part of the small intestine is where things like sugars are usually broken down and absorbed. And this surgery not only restricts you, even more so than a sleeve, which was a banana, because now we have an egg, but it also creates an intolerance to sugars for most patients. So they will experience something called dumping syndrome. And the nurse I work with often calls it the slap on the wrist. So, it could be with foods that are like chocolate and candy and ice cream, but it could also be with fruits that are even like very high in sugar, like cherries. So there's a lot of, learning around that pattern and that behavior, and food, reading food labels is essential because you don't want to be in a situation where you have, cramps and sweating and nausea and vomiting and diarrhea when you're out.
Yeah, for sure. And also, is the reason why I also know there's a lot of malabsorption, so people have to take a ton of supplements. But what about with just the sleeve?
So the sleeve, the biggest concern is a B12 deficiency and B12 related anemia. The reason is the intrinsic factor that is produced in the stomach is then very limited. So they're not absorbing B12 as well through food. A simple supplement orally, like sublingual under the tongue that dissolves, works. There's a once a month shot they can get with their primary doctors, or there's a nasal spray now by prescription that's also available for some people.
Right.
And then honestly, I have a lot of patients who, even with minimal supplementation, their bodies like adapt. So long-term, they may not need even the B12 in addition to a multi. What's in a multi might be fine for them.
Okay. That's good to know. And so I guess the bigger question is what would be the benefits to getting a surgery versus not? And then we'll kind of flip it. But obviously we know that there are some signs and symptoms and side effects, which we will get into. But why would someone choose to get an elective surgery such as any of those?
So the number one reason usually is the amount of total weight that they need to lose, and also diets that they've tried in the past that may or may not be effective. And even I'm talking like medically supervised, very low calorie, like inpatient options that they may have tried. So if they have significant health issues that aren't resolvable, without surgical intervention, that's actually what qualifies them from an insurance company perspective. So there are certain conditions, like diabetes is a main one, where if you're trying with insulin and, metformin and relatively, following a strict diet, but yet your numbers are still in the high 3s, the low 4s, your blood sugar is just very uncontrolled. That's a very, good reason to consider like the bypass surgery or weight loss surgery. So having a medical issue where sustaining your current behavior isn't going to help you long term. So this can add years to your life.
Right. Exactly. So basically what you're saying is that this person has tried to maybe control their blood sugars through food, through lifestyle factors, yet no matter what they do, it's still, for whatever reason, their body's just not responding to it. And so surgery will help them respond to it better.
Okay. Yeah, there's a metabolic shift with the bypass in particular. It's considered the gold standard for someone who has diabetes, and somebody who would have the sleeve may not have as an effective surgery or reaction to controlling diabetes after.
Right. And so let's go through the parameters as well. So they have to have a medical condition that's like a metabolic. Tell us more about the parameters.
Okay. So overall, most insurance companies require that they have a BMI of over 40. So there are BMI calculators online. Anyone can go online and figure out their BMI with their height and their weight. So over 40 without any coexisting conditions for most insurance plans is considered covered because of the higher risk of disease states at a higher weight. If someone is slightly below a BMI of 40, so let's say 35 to 40, they have to have usually 2 coexisting conditions, and that would be something like high blood pressure, diabetes, reflux disorder, sleep apnea, and depending on the insurance company, there may be a few other covered options. But I always tell my patients before they, kind of first visit, like call your insurance company and see what their requirements are.
Mm-hmm. And is there an age as well that's required?
Used to be, but no longer. So now they are doing them like even younger, kind of late teens, I would say. The youngest person I actually had was 16. And we used to have a cap of 65, but that's no longer the case. So it is on depends on health. So you can be very healthy at 65, but you're really just struggling with weight. So if they're cleared by their medical doctors, I think we've gone up to about 70, 72.
Okay. I guess the older I'm not upset about, but I'm having a hard time digesting the fact that a 16-year-old would go through a bariatric surgery when possibly, and you can disagree, I don't know, where I feel like if lifestyle factors were an intervention, it may have been beneficial.
So I really do have to say, I find it to be very individually based. I have not seen many under the age of 18. I will say that. The young girl who I got to meet prior to surgery and after surgery was 16. She had a long history of, obesity from age 5. She was unfortunately, she was one of these 8-year-olds in Weight Watchers, with her mom counting points. She was on really restrictive diets when she shouldn't have been. She should have been growing. She should have been able, but her body just would not lose a significant amount of weight. And at this point, she was probably about 320 pounds. So it was, for her, probably at that point in time, something that long-term would be more beneficial than more harmful. And that's where I say you have to kind of really look at the long-term. If she tried, 16 different things in the last 4 years and all that was happening was weight gain. And she was, they're inpatient for a while too. They have very strict guidelines. They have to follow, protocol with medically supervised diet experts. So that
well, I think, sorry, I just want to say, I just want to make a distinction of the difference between someone in a hospital setting or in a medically prescribed setting and given a regimen and still not responding to weight loss versus the person in the everyday world who I know we probably have all spoken to that have tried every diet in the book and it doesn't work because they don't stick to it or it doesn't fit their lifestyle. That's different.
Absolutely.
Okay. I just want to make sure we clarify because I'm sure 90% of the people that listen to this podcast are like, well, that's me. Nothing ever works for me. Well, because it probably doesn't fit your lifestyle, not because your body's not responding to it. So I just want to make sure that we clear that up.
Yes, no, it is. As I said, I worked in research. So we had participants in a different study who only could eat the food that was pre-packed and provided for them. And that would be an example of someone literally who has been, tested metabolically, what their calorie needs are, and then provided that exact amount that was supposed to also promote weight loss. And then they are following it as best, as they can, but sometimes the reverse happens, right? So, and at this point, there's other medical issues, even at 16 that she was dealing with that were not going to go away anytime soon.
Right.
So
okay. So someone's technically on paper, someone's able to get the surgery. They find out their insurance is going to cover most of it, part of it, however it is. Now, to explain more of the next steps, what is your role in before they even get the surgery? They're just contemplating getting the surgery. What do you do?
Okay, so the insurance companies require clearance from a registered dietitian. So I will always meet with clients prior to surgery to screen and evaluate and assess. I can, sometimes meet with somebody one time. I can meet with somebody 6 times. It really does depend on how much knowledge, information, and ability to sustain long-term changes that they're able to kind of understand on those visits. And once they are cleared by nutrition and psychology, primary care doctor, certain practices have a center of excellence, so they also require things like cardiology, pulmonary, gastroenterology. Once they're all cleared, they will be submitted to the insurance company, and then surgery date is scheduled.
Okay. And so what are you assessing? What makes you clear someone versus maybe not clear someone?
So one of the things that I definitely look at is the criteria just in general. We definitely go over attempts at weight loss made in the past. Many of my patients will have gained and lost 50 to 100 pounds several times. Their ability to sustain the weight loss is also partly like their body's like adapting, their metabolism adapts. So they may be consistently doing the same thing, but they're not seeing any ability to sustain weight loss. So we'll talk about that. We'll talk about even just behavior change. If lifestyle will allow for success after surgery, it is not an easy road after surgery. So, would they be able to do what they need to do in order to heal and recover safely? And then will they be able to have, as I said, like long-term success? I often tell, patients, like, this is not something that's temporary. So if you're kind of not ready to commit, it's going to be a year commitment after, just in the healing and recovery phase.
Exactly. So, okay. So let's get into that then. Like, what happens after surgery? What could someone expect? How is their life going to change?
So initially after surgery, there is about a month period where they're basically on a liquid diet. So they do about 2 weeks pre-op liquid diet, but it's not, it's to shrink the liver. After surgery, it's critical that they follow it so that they can heal. So the area, the incisional site has to heal. So that is mostly like protein shakes and broth and yogurt. And that's a tough thing to do for 30 days. So in and of itself, being able to do that, being able to, take in enough water throughout the day. There may be quite a bit of swelling initially after surgery. So just being focused on proper hydration, preventing dehydration.
Because
and then
they can't drink when they eat, correct?
They cannot drink and eat together. However, they also sometimes cannot drink like more than 8 ounces in an hour. The restriction and the inflammation initially may prevent even fluids from going in adequately.
Mm-hmm. Yeah, right. So, okay. Sorry. So I cut you off a little bit, but so they're on a full liquid diet for even before the surgery. Just also too, I remember when I worked in outpatient, I would have people, I'd have to clear them, I didn't do it for a long period of time, but for a short period of my career, I did. And I would teach them how to separate drinking water with food even before surgery, just to get used to being able to do that post-op.
100%. Yes.
So even before, so it's really not just the month after, it's even leading up to it. So it's like months of, and then your whole life after. But so your whole life after though, right? You can't drink and eat at the same time.
So yes and no. Physically, over time, the body adapts again, and some people can tolerate it, meaning it doesn't make them feel uncomfortable. They don't feel sick. They're not getting nauseous. So they'll drink and eat together. Mm-hmm. However, for long-term ability to sustain that like restriction and that full feeling, we tell you don't continue to drink and eat at the same time. It will make the food empty out of your stomach faster. So you'll be able to take in more. And then that kind of limits the tool, right? The tool is to allow you to feel fuller on a smaller amount of food. Mm-hmm. And that's what helps you kind of lose the weight and keep the weight off. So now if you're kind of working to get the food to slip out of the stomach faster, then it limits, the restriction.
Oh, okay. That's interesting. But going off of that, I mean, I know that you really can't eat a lot at one time. So you do the full liquids and then you start to transition. Let's go through that and then talk about how it's almost like physically impossible to eat large quantities at once.
Absolutely. So as I said, the first 4 weeks, depending on the surgery, the sleeve does give you a little bit more of ability to take in food and liquids. You're looking at, let's say, 1/4 cup to 1/2 cup for the bypass initially, and then 1/2 cup to 3/4 cup for the sleeve initially. Mm-hmm. As the swelling decreases over time, maybe we're working up in the next couple of months to about 4 to 6 ounces of food at one meal. And the meal will take about 30 to 40 minutes.
To eat or to digest? What do you mean by it'll
just
take 40
minutes? To take in about 4 to 6 ounces of food will take about 30 minutes. So if you're not eating fast, you're definitely taking your time, you're giving your body the ability to just kind of see like, where am I in my like fullness, cues? Am I like satiated? Should I stop now? So not everyone has like the same exact ability. I might have 2 patients who have surgery on the same day, and one patient can do a whole 5-ounce container of yogurt 8 weeks out, and the other person might still only be able to do half of that.
Interesting. Okay. And do you notice any of your patients like have certain food aversions that are common, or does that tend to be individual to the person as well?
There are definitely common ones. Both surgeries work to kind of make sweets less appealing and even completely intolerable. So they may drink even a protein shake for that 2-week period prior to surgery, chocolate, vanilla, strawberry, whatever flavor it is. And then that same exact protein shake will literally make them gag. They're like, this is way too sweet. I cannot tolerate it. I've seen that with sleeve and bypass. So a lot of diluting, using unflavored protein powders, being very creative in how we can cut the sweet out of those drinks is necessary. The other common intolerance, sometimes patients have a really difficult time, like even with, which is not always like a bad thing, but like swelly starches. So like pasta and rice and like spaghetti doesn't seem to go down very well with like either surgery. So it's not something that they're going to get protein from. But if 6 months later they're even trying it, they're like, oh, still doesn't feel good. Like I just can't even take 2 bites. It's very uncomfortable. And then for bypass more than sleeve, unfortunately, sometimes solid proteins, meats are very difficult. Even when they're very, like kind of moist and they're chewed very well, they still seem to like sit very heavy. They don't empty out of this tiny little egg-shaped pouch very well. And some people stay away from it for, a year and a half, even longer.
Right. So, okay. So it's safe to say that unfortunately, although your blood sugars might get better and although you might lose this weight, your lifestyle is highly affected and you won't really be able to enjoy food for a while. It sounds like until like maybe about a year is when you can able to like fit a little bit more, have a more variety, or is it kind of like your whole life?
So I definitely have had people come back to me even 6 weeks later and say, I'm enjoying food again. But on a different level, in a different way. A common comment I've had when people come back to me at like the 4-week mark, and I don't know why, but something about hummus is just so delicious when you've been drinking protein shakes for 2 weeks,
That's so funny.
Yogurt, and numerous times I've heard, I ate hummus. Now, not with anything. They literally are eating like a spoon of hummus and they're like, that was so wonderful. And so they're enjoying it. Like they're legitimately like getting some pleasure out of it. And it's like, okay, I'm getting a little protein. I'm getting a little carbohydrate. I'm feeling good. I like it. They'll go out with family members to, maybe dinner and they'll enjoy the soup. Like they'll be like, I'm fine. Like more people will tell me after surgery that initially they don't miss it as much as they think they would have. Mm-hmm. And that partly is the surgical kind of, rerouting and the, removing of the ghrelin hormone. So also resetting of those taste buds, right? You've been doing certain things a certain way. Mm-hmm. I was saying today to a couple of clients that I had today, we were looking back and reflecting, and for some reason, salad is so terribly missed in the first 6 to 8 weeks after surgery. So no leafy greens, no raw vegetables for a long time. And, that's something that they're like, I didn't ever think I would miss a salad. And of all the things that I'm missing, I'm looking at my husband's salad like, wow, I wish I could have a bite of that.
Yeah.
But it's definitely a commitment, and it's definitely making some choices that are going to help you heal and recover, and you don't want to, risk complications. So people are pretty good about following those guidelines.
Yeah, that's if they meet with you and they have the appointments with the dietitian, right? Have you ever had people not show up? Like, will they get in trouble if they don't come to the appointments?
Well, we follow up with them as best as we can. We, do our best to get them in the office. I have, not all programs require, nutrition follow-up. So that's one issue that...
it's a huge issue.
It's alarming because of how many people who do come to their 1 month follow-up 6 weeks later, like they're struggling and they feel awful and they're vomiting and they're, constantly in pain and they're weak, and there's no, good reason, because there are alternatives. There are ways to get around intolerances. There are ways to get around texture restrictions. But to try to figure it out on your own, it's definitely nearly impossible.
Yeah. And then also this just came to me, and I feel like we need to know. So like, I know that you work outpatient, in Staten Island. Not everybody can go see you or need to see you, but you do have an online coaching business, correct?
Correct.
Okay. So I hope this person's listening. And if you are, you know who I'm talking about, but someone had reached out to me on Instagram. We were just talking, and she listens to the podcast, and she had gotten surgery, and she didn't feel like her dietitian was approachable. So this is something I definitely want to kind of bring up. She was like afraid to call her dietitian, and I was like, I would love to help you, but I don't really know the whole story. Like, this is what I think, or I would recommend or suggest, but please verify with your dietitian. And she was just basically saying how she just felt like the dietitian almost like, just, was kind of like, I already told you, like not warm and caring. And so I just want to kind of talk about how not everyone is going to be as beautiful and wonderful and caring as Andrea. And if you have that situation, please don't, that's a problem. And I love dietitians so much, but some of them have stuff up their buttholes that they need to get out. So if you're coming across that, so even if you have the follow-ups and you're allowed to, but you don't feel comfortable going back, there are resources you can go to. So I just want to make sure everybody knows, I'm going to put your stuff on Instagram and stuff like that. But I did have to just say that because I have a feeling someone's probably listening and thinking I don't really like my dietitian. And unfortunately that does happen. But you are not one of those.
I hope not. So I have pretty good following. My clients are actually kind of very open and honest with me. We have a very good relationship, and we have support group twice a month as well. And we have people come who are 3 years out, and they will, if people are asking questions, they'll answer what I would say, which is so wonderful. And then they'll look up at me and they'll be like, oh, is that right, Andrea? Is that okay that I said that? But that's what happens when you have an ongoing meeting with your dietitian. They basically have a very solid foundation. They have a strong understanding of what they need to do. Dietitians have personalities, so they're not always going to match. So, if you're struggling with the person that you're supposed to be with, don't feel like you're locked into it. I don't know what the insurance, kind of initial thing was with that particular program, but, there are definitely other options.
There's other options for sure.
Yeah.
And I love that you have support groups. I think support groups are so, so important. So important. And then, so also, I think we were talking about this kind of before we started recording, but just meeting with the dietitian as frequently as possible is probably going to help with that behavior change and help with the understanding and address any questions that you have after, right? So why is it not a good idea to only eat, say your insurance covers 3 visits and you're like, oh, I'll go 1, 2, maybe even 3. What would be the benefit of going more? Or why should someone, not go to just 3 times and get more support?
The first 3 months, honestly, are very, very challenging. And 1 week to the next, there can be such a huge change in even just what they're allowed to have and what they can tolerate and how they're able to meet their needs. There's sometimes even like a lot of fear around food in the first 2 months just to be able to go from liquids to solids. Doing it on your own causes stress. It causes unnecessary frustration. Sometimes in severe cases, it actually causes complications because people are like, I wasn't really sure. I thought I could eat this. I ate it. Now I'm back in the ER. So 3 visits is definitely not enough. I see people privately, like online coaching every week. So we virtually see each other, but it's every week is a new concern, is a new event. How do I handle a wedding? How do I handle, going back to school? How do I handle even just eating around my kids? And, how do I ensure that I'm mindful and that I'm not going into old habits when I truly cannot even eat these things yet? But, there's this kind of pull back to these old behaviors and these old habits. So, and the first 6 months, there is such a change from day one clear liquids to now acclimating yourself to real life. And, what do I do when I'm at a work situation? What do I do if I'm in a restaurant with friends and family? So I've been doing this long enough. I've heard enough questions. So I kind of have answers that it might take that patient weeks to get. And I always tell, my patients, you can email, you could definitely shoot me a message. And maybe if I'm busy with other people, I won't get back to you right away. But, there's no need to wait 3 weeks for an answer.
Totally. Exactly. That's exactly right. Wow. Yeah. Support is huge. So huge.
Absolutely. And there's a lot of misinformation. So I can't caution people enough. Even if you're not best friends with your dietitian, contact them. Ask your surgeon's office. Yeah. I've even had people get wrong information from certain doctors. So they just weren't 100% sure yet on where the transitional points were. So they're like, oh, my doctor said it should be fine. And I'm like, oh, we don't want you eating that yet.
Yeah. Oh, yeah.
So, yeah.
Yeah. So if you don't know, ask. That's the biggest takeaway.
100%. Yes.
Yeah. So, all right. So what I want to kind of talk about now is the potential of gaining weight back. Because I think a lot of people feel like this is the answer and they're going to lose the weight for good and this is going to work. But people do gain weight back. Is that right?
Absolutely. Yep.
So when does that usually happen? Is it and how does it happen?
Okay. So I kind of say that it happens at different stages for different people, depending on how they've adapted to their tool. So whether you have a sleeve or a bypass, the purpose of the surgery is to help you change eating behaviors over time. And the restriction allows you to eat less and feel full. But if you don't have a thorough understanding of quality of food versus quantity of food, you may start to introduce things that aren't helping you meet your nutrition goals, but yet exceeding your calorie needs. And you may have weight regain in the earlier months, so even before 1 year after surgery. And this is a little easier for someone who's had the sleeve because they do not have an intolerance usually to high sugar concentrated sweets. Mm-hmm. A little longer out with the bypass because, again, as I said, if you're eating high sugar foods, you'll potentially have something called dumping syndrome where you'll physically feel ill. So it'll stop you. And most of the time, it's that slap on the wrist. You're not repeating that behavior tomorrow. Mm-hmm. So it's a component of really getting your mind in the right place after surgery, because eventually the physical limitations start to decrease. So if you can eat a little bit more and you're continuing to follow guidelines and choose the appropriate foods, then you'll sustain your results. But if now you're like, oh, I could fit a little more, I'm just going to eat and fill in the blank with a food that's basically high calorie, empty calorie, and doesn't have a filling effect, then you may start to see your body going in the other direction or your weight going in the other direction. Mm-hmm. Bypass, though, about 18 months, we say, for that inability to digest sugars is typical. And then after that, the body gets a little bit better at taking those into.
Mm-hmm. Yeah. A lot to consider.
Absolutely. We have our, so even after the first year of surgery, we have people coming back like 18 months out, 2 years out, like you're not done. Right. And that's just kind of the whole process of like nutrition. Like your life is constantly evolving and changing and, going from one stage to another. And, we eat all the time. So how I ate last year is definitely not how I'm eating this year. It's not how I'll eat next year.
Or not.
100%. Yeah. So, these are things you need to check in with on a regular basis.
Mm-hmm. Mm-hmm. Wow. Oh my gosh, it's so much great information. I'm really, this is really, really awesome. Is there anything that you feel like somebody needs to know before doing the surgery, or maybe if someone did do the surgery, something that maybe you feel like maybe they aren't doing that they need to make sure they're doing? Like, what are kind of like the things to consider?
So before surgery, the one thing I always encourage my clients to do is really look at your eating behaviors and your eating patterns. And, if you're unsure as to whether or not you should have surgery, I would always say like work with the dietitian first for like a good 6 months before you make that decision.
6 months, not how long? What is the recommendation usually by doctors? Try to lose like a certain amount of weight, right? Like show that you can prove. What's the amount of weight that someone technically has to lose before they could even get approved for surgery? Isn't there like a part there?
10% is usually like the general requirement, but sometimes it's more than that based on like my input, the surgeon's input. Okay. So, we have to ensure that you can follow certain behaviors and guidelines to be successful after surgery and actually to be safe after surgery. Mm-hmm. So we definitely want you to kind of work it out first. Like my surgeon's amazing. He'll meet with people and he'll be like, what have you tried? Well, I want you to do your best between now and 6 months from now to lose weight on your own. It's always the best option. Surgery is not risk-free. So, you need to know that this is definitely like the option for you. The other thing with pre-surgery is which surgery. So sometimes people want to have the sleeve because their cousin had it, their brother had it, their mom had it, but yet they're diabetic. They have a very strong tendency towards sweets. This surgery may not be effective. So now you went and put yourself at risk for a surgery that might not be helpful long-term. It will be for short term, right? Initially, yes, you'll lose weight, but long-term, you may end up right back where you were with high blood sugars, certain medications, weight regain. Mm-hmm. So you don't want to pick one versus the other out of fear. You want to do it based on what your body needs and what you need to be successful. And then after surgery, the big thing I always tell my clients is to really just get a good understanding, as I mentioned before, of like the quality versus the quantity. You are restricted in how much, but there's something called slider foods that, we talk about a lot, things that just kind of will slip into the stomach and slip out of the stomach very quickly. And some people will say, well, now I can eat a lot. Like, what's wrong? It's not working. So you can eat a lot of crackers maybe, but I, haven't had patients who could eat like a lot of chicken, like, what they ate before surgery. So maybe before surgery, they could easily eat like, 8 ounces of chicken at a meal, and that's no problem. But after surgery, no matter how far out, if I ask, like, can you still eat like 8 ounces of chicken like you did before? They're like, oh no, that'll come right back up. So whether or not the restriction is still there, sometimes really it's just the types of foods you're choosing.
Interesting. Very interesting. Wow. Well, this has been so helpful, Andrea. Thank you so, so much. Is there anything else you feel like we didn't talk about that you want to, mention or say?
No, not really. Like, I feel like we definitely got a lot of good information out there for those who are, looking for information. Hopefully they can find my Facebook group. So I do have a Facebook group that you can
tell us more about that.
So the Facebook group is actually called like After the Honeymoon. So it's bariatric support after the honeymoon. And we talk a lot about what the struggles are after that initial excitement of surgery passes. And then for some people, they're talking about serious conditions and struggles that they're having after surgery and how they manage that. So it's a great group of people, definitely clients I've seen from maybe, even 3-4 years ago to now. So it's a good community, a great resource. And I do filter a lot of the information. I'm right now reading everything that's in there because, as I said, we have to be careful with what we're reading. Not everyone's story is translatable to your life. So you want to recognize your individuality and work within your own lifestyle and guidelines.
Awesome. Wow. Okay. Thank you so much. So I'll put your Facebook group in the show notes and your Instagram. Does your Instagram have a link to the Facebook group?
No, it doesn't.
Okay. So I'll put both in there in the show notes.
All right.
Thank you so much, Andrea.
It was my pleasure. Thank you so much. Have a great night.
Bye.
Bye.
I hope you enjoyed that interview. If you did, please screenshot the episode, throw it up on your story, tag me, tag Andrea. Let us know that something we said resonated with you. It got you thinking. We want to know your thoughts. If you have not already subscribed to the Tips with Toni podcast, please subscribe, write a positive review. It allows other people to find the podcast. Honestly, just a simple 5-star rating will do wonders. It's all I would really, really appreciate it from the bottom of my heart. This is it for me today. If you have any questions, you know where to find me. Instagram, Facebook, Gmail, email, tipswithtoni@gmail.com. Contact me, ask me questions. So happy to continue to deliver you value every single week, Mondays and Wednesdays. I hope you're enjoying the episodes. Talk to you guys soon.